This podcast is sponsored by Zoll LifeVest. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hi everyone, Dan Emmender here. On behalf of all of us at Cardio Nerds, we are thrilled to bring you our Decipher the Guideline series for the 2022 AHA ACC HFSA Guideline for the Management of Heart Failure. Get ready for short and bite-sized, high-impact clinical vignette-based questions designed to highlight core concepts based on cutting-edge evidence that are relevant to your practice. The cases we use are hypothetical and for educational purposes only. This series was developed by Cardio Nerds and created in collaboration with the American Heart Association and the Heart Failure Society of America. It was created by 30 trainees spanning college students through advanced fellowship with mentorship from Dr. Anu Lala, Dr. Robert Mentz, and Dr. Nancy Schweitzer. We thank Dr. Judy Bezanson and Dr. Elliot Antman for their guidance. So join us as we get to learn about the guidelines and beyond from 16 leading faculty experts. With that said, it's time to get nerdy.
The following question refers to Section 5.1 of the 2022 AHA ACC HFSA Guidelines for the Management of Heart Failure. The question is asked by Keck School of Medicine and USC medical student and Cardio Nerds intern Hirsch Ellens. Answered first by recent Advanced Heart Failure and Transplant Fellowship graduate and now faculty at the University of Chicago and co-chair for the Cardio Nerds Critical Care Cardiology Series, Dr. Mark Belkin, and then by expert faculty, Dr. Vikram Bozkurt. Dr. Bozkurt is the Marion Gordon Cain Chair, Professor of Medicine, Director of the Winter Center for Heart Failure Research, and an Advanced Heart Failure and Transplant Cardiologist at Baylor College of Medicine in Houston, Texas. She is the former President of HFSA, former Senior Associate Editor for Circulation, and the current Editor-in-Chief of JACC Heart Failure. Dr. Bozkurt was the Vice Chair of the Writing Committee for the 2002 Heart Failure Guidelines. Dr. Bozkurt, it is an honor to have you with us.
It's a great pleasure for me to be with you at the Cardio Nerds. It's a fantastic platform for timely and insightful conversations in cardiology and heart failure. Thank you for inviting me.
Jason, thank you so much for the intro. And Mark, my question for you today is about a 63-year-old patient with a past medical history of hypertension and type 2 diabetes who presents for routine follow-up. He reports feeling in general good health and enjoys 2-mile walks daily. Review of symptoms is negative for any symptoms. Which of the following laboratory studies may be beneficial for screening? Option A is NT-proBNP. Option B, CKMB. Option C, troponin. Option D, CRP. And option E, none of the above. And so Mark, I would love your help figuring out what the next step should be for this patient.
Thanks, Hirsch. That's a great question. It comes up frequently in clinic. The correct answer is A, NT-proBNP. The patient is at risk for heart failure, or stage A, given the presence of risk factors of hypertension and type 2 diabetes, but absence of signs of symptoms of heart failure. Patients at risk for heart failure screened with BNP or NT-proBNP, followed by collaborative care, diagnostic evaluation, and treatment in those with elevated levels can reduce combined rates of LV systolic dysfunction, diastolic dysfunction, and heart failure. The STOP-HF trial, which was the St. Vincent's Screening to Prevent Heart Failure study, is a large single-center trial of patients at risk for heart failure that showed BNP-based screening reduced the composite endpoint of incident asymptomatic LV dysfunction with or without newly diagnosed heart failure. Therefore, for patients at risk of developing heart failure, natriuretic peptide biomarker-based screening, followed by team-based care, including a cardiovascular specialist optimizing guideline-directed medical therapy, can be useful to prevent the development of LV dysfunction, whether systolic or diastolic, or new-onset heart failure. This is a Class 2A recommendation with the level of evidence B from a randomized controlled trial. There is no indication for measuring troponin, CKMB, or CRP at this time. The main takeaway here is in patients at risk for heart failure, screening for pre-heart failure using natriuretic peptide testing followed by team-based care may be helpful for preventing disease progression. So Dr. Bozkurt, I've actually, in my short time now as faculty, I've seen this a few times in clinic. The guidelines are pretty clear on when to screen with natriuretic peptides, but how often do you repeat the testing after your initial screen?
It's a great question. And we examined what was done in this STOP HF trial, which this recommendation was formulated from, they screen on an annual basis. The approach was very well structured, and they randomized to the BNP screening versus no screening. And if amongst the screened ones on an annual basis, BNP levels exceeded that of 50 nanogram per liter is actually a relatively low value. If the level exceeded that of 50, they then referred to this multidisciplinary care coordination that included a cardiovascular specialist. As to one wonders, what did they exactly do? Because these individuals were with hypertension, diabetes, coronary artery disease, but without established heart failure. So what they did was they actually imaged and treated the risk factors very effectively. And when they enhanced this risk treatment strategies, the endpoint was very striking in the sense that both the future development of heart failure, MACE events, and future development of diastolic or systolic dysfunction was prevented. So a very important trial, and that gives us a glimpse into what the structure of the screening could be. So back to your question, STOP-HF trial screened on an annual basis. Perhaps one approach could be the risk. If the risk is high, annual screening makes sense. If the risk is low, like that 23-year-old, one can probably reduce the frequency of screening to several years apart, and maybe only do it when there's a change either in the profile and or in the risk category. So the population-based screening levels rely on cost effectiveness and the pretest likelihood. And the STOP-HF trial actually was further analyzed, and the BNP-based screening was found to be cost-effective, and thus it is likely going to be incorporated in our practice, especially for the patient like the one that you just presented, who truly would benefit from a screening and optimization of treatment strategies that are targeted towards heart failure. And it should be kept in mind that in the STOP-HF trial, there was a multidisciplinary team. In the recommendations that we formulated, we recommend for patients at risk for development of heart failure, natriuretic peptide biomarker-based screening followed by team-based care, including a cardiovascular specialist. Optimizing the guideline-directed therapy can be useful to prevent future development of LV dysfunction, systolic or diastolic, as well as new onset heart failure. The only challenge right now is the recognition for screening is there among specialists. It's not widely known by primary care providers, and it's not widely adopted by the healthcare systems and not covered by the payers. So the importance of this recognition is critical for our patients to be provided timely care. This is very similar to screening for cancer, because we know in heart failure, as we discussed earlier, that there are specific treatment strategies that prevents heart failure. And in individuals who are at higher risk for heart failure, treatment with these specific agents, such as SGLT2 inhibitors amongst patients with diabetes, can prevent heart failure by about 30%. Thus, screening is critical to prevent future risk for development of heart failure. And I think that's going to be an important concept as we, as healthcare clinicians, advocate for our patients for appropriate coverage and timely care.
That's fantastic, Dr. Bozkurt. I think that's a key point about the recommendations and updated guidelines being there, and then that translating into education for clinicians specifically outside of advanced heart failure and cardiology, and then the payers. A follow-up question I had in terms of screening, particularly doing yearly screening in, let's say, a high-risk patient who many of our patients happen to have hypertension, diabetes, and may also be obese. And we know that BNP tends to be falsely low in patients with obesity. How would you interpret BNP screening in this type of situation?
Two answers. In the setting of morbid obesity, we do know that the natriuretic peptide levels will be low. And there are other modalities by which one can examine the heart and the filling pressures, including echocardiography and other imaging. In the context of a morbidly obese individual who may even have symptoms, because most of our patients actually do have symptoms of dyspnea, it would be prudent to obtain imaging in those patients to look at the left atrial size, the mitral inflow, the wall thickness, the structure of the heart in terms of overall ejection fraction, as well as variables that may suggest diastolic dysfunction or even elevated filling pressure. So the concept of screening, I believe, is going to evolve as the field has more evidence supporting these strategies. There are currently large-scale echocardiography data demonstrating very similar role for echo screening. As we are all aware, we have now a very practical focus point of care ultrasound, as well as other imaging modalities that are being widely available. And I think this paradigm is going to evolve with even digital technologies that may look at the cardiac structure in a non-invasive manner. And the ability to detect cardiac structural abnormality may not need to solely rely on biomarkers. In essence, natriuretic peptides are an indirect way of demonstrating increased filling pressures or myocardial stretch. Maybe if we were to have affordable, widely available, practical imaging, they could complement the biomarker screening, or in the setting of obesity, as you alluded to, add specificity and sensitivity.
That's very helpful clarification, and look forward to further screening patients and being able to combat heart failure with the new guidelines.
Thank you. These were excellent cases, and thanks for the discussion and the opportunity to provide the perspective of how the recommendations were formulated in the guidelines with evidence from the clinical trials.
Thank you so much, Dr. Bozkurt and Mark, for that really wonderful discussion.
Thank you. It was a true pleasure.